already had endocrinology today, but Pharm doesn't test all of the clinical treatment or the workup or the diagnosis. Just like endocrine, we give it to you. So we're on a level playing ground when it comes to the things that we need to know about pharmacology for cardiac specific. The indications, contraindications, adverse drug effects, drug-on-drug interactions, the mechanism of action. So make sure that when we're going through the lecture, those are the things that you're focused on and how it's utilized in the underlying disorder, which for today's lecture, which will probably go into Monday. I'm sure it will. We won't get through 73 slides today. We will dig a little deeper than we did in endocrine disorders in the pathophys, unfortunately. But if you don't understand normal physiology or pathophysiology for hypertension, you're never going to understand the drugs, right? A lot of it's going to be a review. I hope that it comes quickly, but if not, you've got to go back in and look and see what happens at the different portions of the nephron, right? What happens in the renin, aldosterone, angiotensin system to know where certain medications are acting and what enzymes are either being blocked or they're being agonized. So we will hit the pathophys or normal phys and the pathophys a little in this lecture, maybe a little more than some of us would like, but you have to understand normal physiology and the pathophysiology of hypertension to know where the drugs act. But the good thing is if you get it in the first lecture of the block, whether that means you're on top of it already, or that means that as you go home and start studying through the block, if you get the importance of the physiology and pathophysiology now, as we move into diuretics, heart failure, angina, acute coronary syndromes, all those things are going to be building on this lecture. So get it now so that you can apply it and own it throughout the entire block, right? And antihypertensives, right? Hypertension, you bet, primary care PAs, you're going to see it all day, every day, right? It's going to be huge in your practice, and you're going to see patients on all these medications, and we'll talk about, stage 1 versus stage 2 versus stage 3, what medications. So unfortunately, there are quite a few different drug classes that we have to learn, but there's some mnemonics, right? We got our old friends, the suffixes in a lot of them. ACEs and ARBs, beta blockers, they all have, for the most part, with exceptions, because for every rule there's exceptions, they all have a way that we can kind of identify them. Identifying them is one thing. Oh, I know that's a beta blocker. Okay, well, what does it do? Where? Oh, and by the way, it does something different in the heart than it does to vessels, or if it does in the brain. So there's a lot of options, but be patient with going through the phys and the pathophys, then you'll own the medication and the pharmacology for it. No difference here. Big things we're looking at, I just mentioned. How we're going to use the drugs, mechanism of action, common and significant adverse effects, contraindications, like Pharm, those are the bullets that we test. So therefore, when I'm preparing for a Pharm test, that's what I'm focusing on. We give you the diagnosis, just like this morning. Abbreviations should be a review for both cohorts here, sophomore and junior, right? But if you don't know what they are, I'm going to say ACE, I'm going to say ARB, I'm going to say BUN, CCB. I mean, I may say them once or twice through the lecture, but my hope is that you already own these, or you get to own them pretty soon, because I'm going to repeat them about 1 million times. So make sure that you know what I'm talking about when I use these abbreviations during the lectures, right? So definitely in today's lecture, we may get it to the angiotensin II receptor blockers. We'll definitely get into the angiotensin converting enzymes, and then we'll get into the diuretics. And those are on the further slide when we talk about what meds we're going to get into. But make sure you know these definitions. Don't confuse the ACEs and ARBs, because they're acting at a different part of the highway in the RAS system, which is that last bullet. I'm not going to say renin, angiotensin, aldosterone system all day long. I'm going to say RAS or RAS. system. So make sure you understand that when I say that, I'm talking about the entire pathway so that you can understand and apply where the meds are functioning at and what they're blocking or agonizing, yes, assisting with in the ROS system. Not a whole lot of meds. There's a whole bunch of meds in each of those classes, not a whole lot of classes, but for the most part, we can see there the ACEs are going to end in Pril, ARBs, Sartan, calcium channel blockers. We have different categories of the calcium channel blockers. We'll talk about DHP versus non-DHP. So DHP is just an organic compound that acts in oxidation. You don't need to know that. You just need to know that there are calcium channel blockers that have DHP and there's the non-DHPs, because that determines if the calcium channel blocker is more cardioselective or not. Same kind of thing applies to beta blockers, right? We got our suffix there, the LOLs, but then we have some that are non-specific, then we have some that are specific, and that'll be in future lectures. And then there's a couple of one-offs, right? Prazosin, alpha-1 blocker, direct vasodilators, hydralazine, and the nitrates, so we'll talk about those. But definitely pay attention to the suffixes throughout this lecture and the remainder of the block. There's exceptions, like I said, to every rule, but for the most part, you can pick them out of a lineup by how they end. So how do we define it, right? Hypertension. For us, we're going to say sustained elevation in blood pressure. Currently, we're going to use the numbers as systolic blood pressure greater than 130 millimeters of mercury, or diastolic greater than 80. Or, third caveat, if you're taking an antihypertensive medication, or your patient is. So that's what we're going to say is hypertension. There are guidelines out there. PANTS states they don't test guidelines. Okay, they don't say from this guideline. However, you're expected to know and understand whether it's stage 1, stage 2, stage 3. And how many of us know that there's a 2025 guideline out there for hypertension? Right? There's a 2025, which updated the 2017. So you're going to see some reference in the slide deck to ASCVD, atherosclerotic cardiovascular disease risk factor, right? That was the one that's been being used since 2017. That's the one that's currently on the PANTS. Now, 2025, American Heart Association, American College of Cardiology, everybody got on one team, because what is confusing in a lot of things and what was happening since 2017, American College of Cardiology said one thing, American Heart Association said one thing, but now there's guidelines that are supported by every major American AFP, the family physicians, American Association of Family Physicians. So all of the different organizations got together and we have one guideline. It is included at the end of this slide deck as an FYI after the memory jogs. The only real difference is how aggressively the new guidelines recommend treating folks with hypertension and other comorbid disease, right? How aggressively, now just not saying, hey, below 130 is no longer hypertension. They state, oh yeah, we agree with 2017, below 130 we would say no longer hypertension, but if somebody has a comorbidity, another cardiovascular issue, diabetes, chronic kidney disorders, those kind of things, let's try to get them down to 120, right? That's really the big difference. And then the percentages for the risk factor staging are roughly the same. When we say 5% versus 10% versus 20% of having an acute cardiac event within 10 years. But instead of seeing ASCVD, you'll see prevent. So if you see these on the exam for our purposes, because by the time you get to phase 2 and by the time you're out getting ready to finish with IPAP, getting ready to take your PANTS, prevent should be what you'll see as the screening tool. A lot more demographics in the prevent than the ASCVD. There is a hyperlink on here so you can go ahead and read about ASCVD and the 2017 guidelines. And there's also one at the end of the lecture for 2025. But the definitions on this slide are what we're going to consider hypertension. And then I'm going to give you some guidelines for what we're going to say is stage 1, stage 2, stage 3, because that determines how many medications from what classes we have to utilize. So go with our definitions, knowing there's these 2 different guidelines. There's many if you look before 2025, but there's right now 2025 and on, we have one guideline to look at, and that uses prevent. If you see ASCVD in a STEM anywhere in this course, it's going to help you. It's not your defining metric to decide what we're doing with the patient, right? So that's going to be just like there's stuff in all the vignettes that say, you know, you have to pull out the important information. You may see ASCVD listed there. You do not need to know the ASCVD to answer that question. Everybody clear on what I'm saying there? Might be part of the STEM, but it's not going to, you're not going to go, oh, now I'm going to do this instead of that. So as long as you stick with what I'm telling you on the slides, acknowledging that there's some guidelines out there that are recently updated. So let's go with this definition for hypertension, the systolic number, the diastolic number, or people that are on antihypertensive medications. And then when we get to staging of hypertension, I'm going to give you the parameters that we use, which are pretty much exact same ones that 2017 used, 2025 is using. There's just some goal changes with 2025. Some more definitions here. Resistant hypertension. That just means the patient is not at goal, even though he's on 3, or he or she is on 3 medications, and preferably one of those medications is a diuretic. Ideally including a diuretic. And then isolated systolic hypertension is a little bit different because here, usually it's going to be adults where just the systolic blood pressure is elevated, and that's due to arterial stiffening as we age. So just be aware of the definitions there. And then also there's a note there on pulse pressure. Pay attention to it. Wide pulse pressure greater than 60 suggests the same thing, increased arterial stiffness. So now we're going to get into the physiology, everybody's favorite thing, right? We're going to reach all the way back to freshman semester. But it's important because every hypertension medication that we're going to discuss is going to act somewhere in the normal physiology of blood pressure regulation for us to be able to get the desired effect. So core equation, right? Most important equation throughout this block is blood pressure. Blood pressure equals cardiac output times total peripheral resistance. So when we talk antihypertensive medications, we're talking about something that's either affecting cardiac output or total peripheral resistance. Because drugs are either going to decrease cardiac output or they're going to decrease peripheral resistance. So if you get stuck on exam, you need to think, what are we trying to do here? Or what does this medication do? You know, is it going to be affecting the cardiac output or the vessels and the total peripheral resistance? Cardiac output primarily influences systolic blood pressure because the cardiac output's going to depend on how fast the heart's beating, how much blood's being moved each time the heart beats, so stroke volume, or how much blood is coming back to the heart for it to pump, so venous return. And then you can kind of think when we get into the classes, anything that's going to slow the heart or decrease how hard the heart is pumping or the contractility of the heart, that's going to lower systolic blood pressure. And then we'll talk about specifically as we get into the classes, which medication classes do that. And then the total peripheral resistance, or the TPR, is mostly going to influence your diastolic blood pressure because it's driven by the vascular constriction, and we talked about elderly, right, getting those stiffening arteries. So also the vascular remodeling or any hypertrophy that takes hypertrophy or changes in the vessel walls that take place over time. And then we'll talk about what medications act there. Because chronic hypertension is not just about tight vessels being clamped down. It's structural changes over time that also can lead to worsening of hypertension. Important note there at the bottom, our blood pressure fluctuates throughout the day, right? It doesn't stay static. A blood pressure early in the morning versus late at night could be different. So it matters clinically. That's why we have people do like blood pressure logs. Like we may say, take it in the morning, take it at lunch, take it in the evening to kind of trend. Where is this individual patient's blood pressure fluctuating? When and what time of the day? Because that can affect what time we want to give them their medications, for example, or clinical therapy that may change depending on what this patient's normal blood pressure rhythm may be, how it's fluctuating throughout the day. Usually the lowest while we're sleeping, which kind of makes sense because we're not moving much. Big chart, big slide, right? So basically what we're talking about here is this interaction between the sympathetic nervous system and the renin or the ROS system there at the bottom, renin-angiotensin-aldosterone system. Because both things, the sympathetic nervous system and the ROS system, interplay. And this is just showing how they interplay to control blood pressure. And if you just start over there where it shows the blood pressure is going down, and I'm not going to read through the entire chart, but on the far left, when the blood pressure goes down in the middle of the diagram there, you see renal blood flows decrease, and that's going to increase renin. The GFR through the kidney is going down with a decreased blood pressure. That's going to cause the kidney to allow sodium and water retention, and then we start following the arrows up, right? And at the end of the day, all the actions at the sympathetic nervous system combined with the system in the ROS, which we're going to talk about next, are all going to combine to increase blood pressure. So the outcomes you're going to see on the far right, blood pressure goes up, right? And then on the top there is all the methods that are happening, responses that are mediated by the sympathetic nervous system, right? And that's going to help us when you look at those three boxes in the middle, when we start talking about the sympathetic activity, because a lot of those we're going to utilize to our advantage when we treat hypertension, right? Because we're going to talk about, well, what's going on with beta-1 stimulation of the heart? What's going on with alpha-1 stimulation in the vessels? And we're going to get into each of those. But this is a good overview if you get lost in the sauce as we're going through the lecture and when you're studying, to go back and say, okay, why are we using that medication? Because of what activity that's happening either in the ROS system, or what are we blocking in the sympathetic system, those adrenergic responses by this medication? So this is just a 3,000-foot view of what's happening when our blood pressure goes down. But you can look at it like, well, if all these things happen to bring our blood pressure back up when it's down, like it is on the far left with the arrow going down, well, what if we're constantly elevated? Then that just means we can do something at almost every stage of these responses to low blood pressure to block those actions at the heart or at the vessels or centrally to help keep blood pressure low. So the ROS, the renin-angiotensin-aldosterone system, right? Most important long-term regulator of our blood pressure in our bodies. Also is going to regulate sodium, potassium, and our fluid balance. Should all be reviewed, but if you're not still tracking it, if it's been dumped since freshman semester, make sure you know what normally happens in the ROS system. So, like I said, regulating sodium, potassium, our fluid balance, it's going to influence our overall vascular tone, and it's going to interact, as we showed on the last slide, with the sympathetic nervous system. So make sure you know what's happening normally in the ROS system so that when you look at this slide and you say, oh, that angiotensinogen made from the liver, needs renin to turn it into angiotensin 1, we have some things that could block that. Oh, what about the conversion of angiotensin 1 to angiotensin 2 on the left side there with angiotensin convertive enzyme? Well, the I in ACE inhibitors is the angiotensin converting enzyme inhibitor. So guess what? That's where that class of medication is acting. So if you understand this, then a lot of the times you can, without even having to memorize, you can figure out, hey, I know that this drug is in this class because of its suffix, and I know it does this. It inhibits the angiotensin converting enzyme, so it won't make angiotensin 2. So you don't have to memorize a lot if you understand normal physiology. So when we talk about the ROS system specifically, once again, like I said, hopefully a review. If not, dig a little deeper. But let's just think about everything pretty much starts at the kidney. You've got some cells, the juxtaglomerular cells, and you can see them on their slide. They're abbreviated JG there on the picture on the left. And they're in the afferent arteriole. They're basically baroreceptors. What does baroreceptor mean? So they're responding to pressure, right? To pressure or volume. So they can sense, those juxtaglomerular cells are going to sense, based on volume and pressure, decreased renal perfusion, and they can also sense decreased sodium delivery to the distal tubule. I'm not going to ask you questions, and the PANCE isn't going to ask you questions about the juxtaglomerular cells. You just have to understand how this process works so we can get to the point, which is what medications can we use to do what in this system, right? And also, when you get increased sympathetic stimulation, the cells release renin, which you should have seen on that last slide when we're talking about the RAS, where renin is. And we're going to talk about what it does and do we have things that can block it or not. So the renin is the kidney's way of saying, I think that the blood volume or the blood pressure is too low. So we kick it out, and we'll talk about how coming up. So renin itself does not raise the blood pressure. What it does is going to convert, if you go back to the last slide, that angiotensinogen from the liver into angiotensin 1. So you do need to know what renin's doing. And it's there on the slide for you. And once renin converts the angiotensinogen from the liver into angiotensin 1 does nothing. It's biomedically inactive, right? It does nothing in our bodies. So it's an inactive precursor. But angiotensin 2 does a whole hell of a lot in our bodies and in the RAS system and for fluid and electrolyte control. But angiotensin 1, its only use is to be converted to angiotensin 2 by, guess what? Angiotensin converting enzyme. So an angiotensin converting enzyme inhibitor is going to block what to what? Angiotensin 1 to angiotensin 2. That simple. So angiotensin 1 to angiotensin 2, the angiotensin converting enzyme, or ACE. So ACE, or the angiotensin converting enzyme, primarily in the lungs, if we remember that. Primary in the lungs. So that's why the pulmonary circulation is going to play a key role. Angiotensin 2 is one of the most potent vasoconstrictors in the body. So once we get ACE converting 1 to 2, now we have a bioactive substance in our system, angiotensin 2, one of the most potent vasoconstrictors in our body. So that angiotensin 2 being a huge vasoconstrictor, that's going to be where a lot of our blood pressure is coming from. Our elevated blood pressure is the potent vasoconstriction from angiotensin 2. And it does it, and it's on your slide in a lot of ways, right? So what does angiotensin 2 do? Constrictor So angiotensin 2 is going to affect that aldosterone release from the adrenal cortex. Also, angiotensin 2 is going to drive increased sodium reabsorption in the kidney. It's going to increase the heart rate. And here's something else, a blast from the past, right? Blast from not the far ago past, but it's also going to increase ADH release from the brain. But when you look at all of those actions of angiotensin 2, now you can see why if we block it and inhibit all of those actions, that we can have such a large effect on blood pressure control. And guess what? The way we're going to do that, ACE inhibitors are ARBs. Just at the bottom of the slide there is just a little jog about aldosterone, right? The distal convoluted tubules, what does it do? It increases sodium reabsorption into the blood, and it increases potassium excretion. But remember, especially as we get into diuretics, what does water do with sodium? Follows it. So keep it in mind that the water is going to always follow the sodium. When we start talking about normal physiology, we are excreting sodium here or reabsorbing sodium back into the blood here. Well, when we start acting on certain parts of the kidney, specifically the nephrons, then we can affect actions of whether or not that sodium and potassium is going to be reabsorbed into our blood or not. And if you understand that, then you'll understand what some of the adverse effects of some of the medications we're going to talk about. Because if we're affecting aldosterone, which regulates potassium secretion, and if we're inhibiting potassium excretion, so what's happening? If we inhibit potassium excretion, so we inhibit aldosterone, which affects potassium secretion out through the urine, we're inhibiting that. So what happens to the potassium if we inhibit aldosterone's action? It starts going up in our system because we're no longer excreting it, right? So if you understand the process, the adverse effects come naturally. So here is just a big overview of the ROS and this entire lecture and future lectures. If you look, you can see everywhere where there's the orange with the orange circle with the white kind of hash mark. Those are our drug classes, and it's showing you in the renin-angiotensin system or the ROS system where each of the drugs are going to act. And the drugs on the right, bottom right there's your key. RI, renin inhibitors, ACEI, angiotensin converting enzyme inhibitors, are ACE inhibitors, ARBs, the angiotensin 2 receptor blockers, which we're going to talk about in depth, and then the calcium channel blockers. But this is also a very good slide. Now we're overlaying our ROS, what's happening normally with now our antihypertensive medications and where they're acting at and what are they doing. And throughout the lecture, when we're talking diuretics today, keep in mind, and I don't want to say it a million times because I'm sure you get tired of me saying it, but we're talking today for antihypertensives, we're talking thiazide or thiazide-like diuretics. We got a whole lecture probably starting Tuesday, maybe even Wednesday, that's the other diuretics. There's loops, there's a whole bunch of different diuretics, but just keep in mind when we start talking about diuretics, right? Like the slide there on your picture there on the left, we're talking about thiazide and thiazide-like, and we'll get pretty quickly to what they do. But a lot of the slides just say diuretics. For this lecture, it's thiazide and thiazide-like diuretics. Then we'll move on next week. Finally, treatment. That's why we're here, right? All that other stuff, we own it. We know normal physiology, so let's talk treatment. So here's the stuff I was talking about at the beginning of the lecture. This is your backbone slide. I don't have the little fox with the money. I don't know where it came from, but if I had one, I'd put it on here and have them spinning around, throwing dough, right? Dropping bills, because this is kind of where everything lives for our hypertension lectures. Stage 1, there's your numbers. Stage 2, there's your numbers. Pregnancy, oh, that's special. We got to look at different things. Good news, we're going to talk about only 3 medications we can use in pregnancy, so not a huge lift. And then that specialty we talked about with isolated systolic hypertension, usually you're elderly due to changes in the peripheral vasculature, and we only have to talk about one drug there that we're going to talk about as a primary for stage 1 or stage 2. So the key here is there's, on the far left, stage 1 ASCVD risk. These are the 2017 guidelines, right? Less than 10% lifestyle modifications, greater than 10%. 3 different drug classes, star, underline, bold, pick one. It's stage 1, pick 1. Stage 2, pick 2. Unless there's special populations or special circumstances. And we'll talk about what those may be. When you can use those backbone, we'll call them, backbone first line medications, and when you can't. We'll give you the exceptions. But know this slide, straightforward, know the numbers. Don't worry about calculating ASCVD risk. I'm not going to give you a question and say, oh, the ASCVD is 15%. Do you want to do lifestyle? Do you want to start? If we say it's stage 1 based on the numbers, we're going to say give medications, which is more what the 2025 guidelines are moving to. And especially more if the more highly recommended if there's comorbidities, any kind of chronic disease disorder. So like I said, don't worry about the percentage. It's a bonus if it's in your question. We're going to go with the numbers. And guess what? I told you at the beginning, and we've talked about it in every Pharm lecture, I'm going to give you the diagnosis. We're going to say they have hypertension and a number. And if they're already on a medication, because as you've probably already picked up on, a lot of Pharm is what's next. Okay, we're on, your patient had stage 1, but now his numbers are telling me stage 2. Excuse me. So we're moving past pick 1 from the 3 backbones, thiazide, ACE, or CCB. So now what, right? We can switch the primary one he was on and pick 2 new ones from those 3 classes, or we can keep what he or she was on and add another from those classes. Dependent on comorbidities, as always. So the take home here is that all those drugs that are in our backbone, the pharmacotherapy lowers blood pressure differently. They all lower blood pressure, some with more efficacy, some with less, but it's a different pathway, different mechanism of actions of all of those backbone medications. So that should tell you one of the most important things is understanding the different mechanisms of actions and being able to recall the different mechanisms of actions for the different first-line medications for hypertension. Great news is that half of them are in the name, right? ACEs, you know what they do. ARBs, you know what they do. If you can remember what the abbreviation is, you got that licked. Beta blockers, you know what they do. They block beta. So as long as you understand the names, you should be able to hash out what a mechanism of action is. And then you got to also think about, well, where in the case of diuretics. Okay, yeah, we know they cause diuresis, basically you peeing more, losing water, but where do they affect, where do they have their effect in the nephron? What portion of the nephron? But the diuretics, thiazide and thiazide-like, are going to lower your BP by depleting the sodium. You're going to pee it out, which means less volume and less sodium. If you're peeing out sodium, the water's following. Remember, water's going to follow sodium. And the two, when I have the bolded drugs there, that's the class representation, right, for each of the drug class. So diuretics, hydrochlorothiazide, thus thiazide diuretics. Really only one other big player. There's 2, but the other big player you need to be aware of, chlorothalidone, and that's why it's called thiazide-like. Has the same actions, right? Then we have direct vasodilators. They're going to reduce BP by relaxing the vascular smooth muscle. It's in the name. It's a vasodilator. So dilates resistant vessels and increasing capacitance. So increasing the ability for fluid to move through. And those are your nitrates. If you think about it, I mean, you've probably already have often heard of folks with angina take a nitroglycerin pill, right? Why? It vasodilates. Pretty straightforward. Nitrates vasodilate directly. And then we're going to talk about the ACEs and the ARBs. I've already mentioned their names tell you what they do and where, and whether it's blocking a receptor or whether it's acting to inhibit an enzyme to keep it from making angiotensin II. And their action is going to reduce peripheral vascular resistance, both ACE and ARBs. Those two, if you go back and you notice on our treatment algorithm, those two, it says ACE or ARB. But we'll talk about the eaches and why we would choose one over the other. A lot of times we're going to go ACE, and then if we have some side effects, then we might go ARB. Or if we have some severe side effects, we may say no ACE, no ARB. Let's think about something else, but that's a coming attraction. So, and then we have some specific anti-adrenergic agents, right? Because we can affect things up at the central system. So drugs that either cause an increase in or a decrease rather in the heart rate or in the pressure, right? The force of the contraction in the case of inotropic actions. Or we have some central actors that can reduce peripheral vascular resistance, which leads to decreased cardiac output. And then we can also have some agents that have an anti-adrenergic effect that increase venous pooling in the vessels. So we'll talk about those eaches and the circumstances for them as well. Starting with diuretics, specifically just this class of diuretics, or what we're thinking with hypertension. Our other classes of diuretics come into play if there's a contraindication to thiazides in hypertension, or when we start talking about comorbidities. Specifically, some are more recommended in things like heart failure, or heart failure with reduced ejection fraction, those kind of things. But for now, when we're talking diuretics for hypertension, when we talk about our backbone, it's this class, which just include the three drugs there, right, or four: hydrochlorothiazide, microzide, thalitone, and then the metolazone. So now we are here at the kidney nephron, right? So the diuretics. Chloride reabsorption in the early distal convoluted tubule. You need to know that. You need to know where the action is taking place and what's happening. So normally in that distal convoluted tubule, which you see there with the four, all the diuretic site actions are listed on the left. Some will be talked about in future lectures. Now we're down at number 4, the thiazides. And you see where the red dotted box is, top kind of upper right at the distal convoluted tubule, where we're normally getting the reabsorption of sodium and chloride back into the blood. If you inhibit that, then where's the sodium go? Out with the pee, right? So then where does water go? Following the sodium out with the pee. So that's basically how it works. Right? We're inhibiting with our thiazide diuretics the reabsorption that normally takes place with the sodium and the chloride in the distal convoluted tubule. Something to know that is tested sometimes, the concept, right? When we first put thiazides in, yep, we're going to lose volume. So the blood pressure is going to drop. It's going to drop by that volume loss. But there is peripheral resistant changes that will, over time, the volume is going to get back to normal. So your patient is not going to be hypovolemic on diuretics or thiazide diuretics for the rest of their lives, right? Initially, yeah, they're probably going to be hypovolemic, PPs following sodium out, right? But over time, there's remodeling. Your patient is going to become euvolemic. They're going to have a normal return of fluid. However, the peripheral vascular resistance is going to remain low on the thiazides. So don't think that, oh, your patient, now maybe they don't get all the way back to euvolemic state, but there's remodeling in the vasculature system so that there's that initial flow, volume down. Volume will normalize, but the diuretic, specifically the thiazides, will cause a prolonged peripheral resistance lowering even once the patient becomes euvolemic. So why do we use thiazides? Why is that our backbone? Because all the data says we should. All the long-term data is super, super strong regarding decreased mortality, morbidity from hypertension with the thiazide or the thiazide-like diuretics in this class. So they can lower systolic BP by 15 to 20 millimeters of mercury and diastolic by about 8 to 15. This isn't an instantaneous thing, right? Usually a month, 5 to 6 weeks. It's not going to be instant, right? Because those changes in the peripheral vascular system isn't going to change overnight. There will be some pretty rapid loss of fluid, but you're going to have that amount of lowering, the numbers I just gave you, about a month and a few weeks, so about 6 weeks. So we're never going to, except for some hypertension urgencies and emergencies we're going to talk about, nothing we're going to give the patient is going to like rapidly drop it. There's cautions with that, but there are sometimes we'll talk about, I think, almost at the end of the block, hypertensive emergencies and urgencies. We'll hit them today, but we'll hit them again later in the block. We'll touch on them, maybe not today, but in this lecture. But for the most part, when we're treating our patients outpatient, they're coming in and leaving with medications, and then we're not in the ER or they're not being admitted. It's a slow process, right? We slowly drop that BP. It's weeks or months, not days, except for in the exceptions I'm going to give you. So thiazides and thiazide-likes specifically, when I talked about those 2025 guidelines being updated, if you just have all this extra time on your hands, click on the link and go read about all the data that shows what thiazides and thiazides-like do for hypertension. So they can reduce strokes, reduce major cardiovascular events, they reduce overall morbidity and mortality from hypertension. So this little water pill, right? This little water pill saves lives. Most data for hypertension, mortality and morbidity decrease out of all the drug classes. They're not good for everyone. Not effective, and you definitely need to know that the renal precautions with the thiazides, right? Not effective if you have inadequate kidney function. So if your creatinine clearance below 30 and our serum creatinine greater than 2.5, we're not using thiazides. And that's future lectures to talk about what we will use. But just remember there's renal precautions with the thiazides. You'll often, little pants pearl, you'll often see on pants a patient being treated that is not having a good outcome, right? So the key will lead you towards, hey, they're being treated with a thiazide and this many milligrams, and it's not, your patient's not responding. And then they'll throw in there some kidney labs, right? And you'll see that the creatinine clearance is decreased, or the serum creatinine is up, or the BUN is off, and then you need to know, we look at going to a loop diuretic. Works differently, but we'll get there. For now, just know that the renal precautions for it, for thiazides. Adverse effects. Most common for the thiazide and its thiazide-like partners in this drug class. Hypokalemia. Not a giant number, but about 10 to 15% of patients will have a hypokalemia. But you should know now that hypokalemia can be bad, right? Causes a lot of things. Muscle weakness, fatigue, heart arrhythmias, AFib, VTAC, you name it. can also get that numbness and tingling associated with hypokalemia. So what do? Check labs. For all of the antihypertensives, labs are important, right? So monitoring the patient, checking their potassium. When you put them on a thiazide, usually a couple of weeks to a month, go ahead and look at that potassium again. After they're stabilized and you're not changing dosing around too much, it's just a couple of times a year. You can add supplements. We can also get hyponatremia. Why do we get that? Because the hypovolemia from losing all the fluid is going to trigger something that you should absolutely know, right? ADH. ADH is going to be triggered, what you learned about last week, because of the hypovolemia. So your brain's going to say, let's kick out some ADH. And then you can also get some reduced kidney diluting capacity and increased thirst. So how's your exam going to present this? It's going to say, patient. A couple of times, but now we'll talk about why. Gout can be worsened by thiazide diuretics. Remember that was last test when we taught gout. So you knew the answer because we said, hey, just know it for now. But basically, as it says there at the bottom of your slide, that thiazides increase uric acid levels. Why? Because they compete for excretion in the kidney. So can lead to gout, right? And then we all know that what happens when those uric acid levels get too high, we start depositing in joints, and you've already been there and got the t-shirt, so we won't dig too much into gout anymore. I expect that you own that, but now you understand the pathophys behind why thiazide diuretics, because of that competition in the secretory pathway, is going to cause increased uric acid. Direct competition for the transporters. So let's go ahead and take 10. We're definitely not going to go the whole next hour. I can see the fade already. I know it's Pharm, everybody loves it. So we'll get back and get started probably. I'll probably get through 5 or 6, maybe 10, according to how quickly we get through it, slides, and then we'll get you out of here. But I would say 15 minutes after the break, 20 minutes, unless everybody in both classes wants to just drive on. Can y'all hear me over there? Sophomores? Everybody good to keep pushing for like 15 minutes? Who doesn't care? Raise your hand higher. All right. Hey, we're going to drive. We're going to round up those folks in the bathroom. I'm kidding. All right, yeah, just if you need to go. We'll just talk. I want to finish up diuretics at least. But we have 8 lectures to get through it, and it's all just as fun as this. So we can get you out of here to go work on your final draft of your paper. Right? All right, so adverse effects for the diuretics. You do need to know you say dosing doesn't matter, but for our thiazides, above 50 milligram of thiazide, we can start looking at hyperglycemia. So the actions and why is listed there for you. It's going to impair the release of insulin and the tissue uptake of glucose. So hyperglycemia at dosages higher than 50 milligrams of diuretics. We can also get hypercalcemia because, as we mentioned on the last slide, we have a limitation or an inhibition of the secretion of calcium with those thiazide diuretics. So if we're limiting the excretion, then guess what? It builds up in our blood. And then we can get all of those things that you probably learned about back in freshman semester when you have hypercalcemia, right? Everybody remember those, right? Arrhythmias, confusion, fatigue, muscle weakness, GI tract, kidney stones. And then volume depletion, kind of talked about it already, that, you know, the urine, the water in your system is going to be following the sodium out, so we can get volume depletion. It can cause orthostatic hypotensions, right? You stand up too fast, not getting enough blood flow to the brain, get syncopal, pass out. Definitely need to know the last bullet on the slide. Sulfur. Sulfur sensitivity no-go with thiazides or thiazide-like. Definitely comes up a lot. It's not an absolute contraindication, but use with caution if your patient has any or may have had any sensitivity to sulfur in the past. Now we're to one of our big guns, right? ACE inhibitors. That's all we're talking about for diuretics for hypertension. Except for the fact, if you look at the right column with our ACE inhibitors, ACTZ with all of our ACEs. What does that mean? It's just a combo pill. ACE inhibitors with hydrochlorothiazide. Because those two drugs play well together, and they're indicated for so many of our patients, when we get to that stage 2, a combination, you'll see the ACEs and the ARBs often have a component where you have the hydrochlorothiazide. Usually what we do is kind of start with the separate of each one, get them dosed right, get them where we want them, and then we can find the pill that matches, right? Because it comes in a lot of different product packaging as far as what milligram of the ACE versus what milligram of the hydrochlorothiazide. So normally kind of start with 2 different bottles. Once you get your patient straight, we're good. Labs have been trending where we want them to trend. We can move to a combination pill of those 2. So we do have the suffix for our ACE. I would learn now the stars, because the stars are also useful in heart failure, not just for hypertension, because that's coming up. So since you're already looking at the ACE inhibitors, know that the ones indicated by the little asterisk there, those can be used in heart failure as well. And then there's one there with the red, IV only. So guess what? It ends differently from all the others, right? It's still got the prill, but it's got a couple of extra letters there at the end of it. So that's your ACE that's different in that it's a different name, different suffix, and it's IV only. But that will come into play when we start talking some other treatments beyond just hypertension. One thing to know about the ACE inhibitor, and it's when we talk about indications coming up on the next slide, is that the ACE inhibitors don't just lower blood pressure, right? They don't just lower blood pressure. They do a great job of it, but they also protect the heart and the kidneys. And so you're going to see ACEs with strong comorbidities, like what we generally consider bad comorbidities, badness, right? Those chronic disease processes that we usually say, can't use this and that, or you be cautious here. A lot of those badness disease processes, we say, definitely throw an ACE at it. because of their kidney and cardioprotective function. So then what is that telling us, right? Basically that using an ACE sometimes, we're modifying the disease process, right? A lot of medications that we talk about for different disease processes, we're just treating symptoms. But for ACEs, we can actually modify disease when it comes to hypertension, not just treat the symptoms. So what do they do? Things that angiotensin II does, both in the central nervous system and in the peripheral vascular system and at the kidney. So we're blocking all those actions that we mentioned of angiotensin II because we're blocking the enzyme that actually converts angiotensin 1 to 2. Remember, ACE is in the lungs, right? That's where it's mainly made. There are a little bit of some ACE is made down in the kidneys, but mainly in the lungs. So when we talk about and think about the actions of angiotensin II normally, then when we talk about inhibiting that conversion, and we're going to reduce heart rate, and we're going to reduce that antidiuretic hormone release that we said was a rebound effect from what? All the volume loss. So does a lot of great things to counter an overactive RAS system, right? However, we do bradykinin is thought to cause all of our adverse effects, which can be significant. So the bradykinin is it's responsible for a lot of vasodilation, and so we're inhibiting it. So our adverse effects can come from that bradykinin building up and having increased levels. This is just showing that action. Once again, the red circle with the cross, you should be able to go back, or the hash, you should be able to go back into that main RAS and see, but this is just a blow up of that one portion. The ACE inhibitor, obviously inhibiting the angiotensin 1 to angiotensin 2, which means it gets, or it blocks, keeps from happening all those downstream effects of angiotensin 2. So in hypertension, but we're not getting any heart-specific changes when it comes to heart rate or the force of the heart contracting. So ACE inhibitors reduce preload, they reduce afterload, and they reduce cardiac work. That's the reason that you saw the reason that you saw the little asterisks and the stars is because of those actions. That's why they are important to the drug classes that are utilized in heart failure. So our friend or foe, bradykinin. The slide says ACE. Bradykinin therefore goes up. What does bradykinin do? It stimulates nitric oxide, it stimulates prostacyclins, basically you need to know that bradykinin is a vasodilator. So we would think that would be great for our hypertensive patient put on an ACE inhibitor. Yay, it also is inhibiting bradykinin because ACE isn't going to break down the bradykinin because of the ACE inhibitor on board. However, with the increased bradykinin, that's where we start to get a dry cough and angioedema, which are the two big side effects for ACE inhibitors, directly due to the fact that ACE can no longer break down bradykinin, and those the bradykinin elevates with our ACE inhibitor on board. And we got some pictures coming up showing you that. And we'll just finish this slide and then we'll be done. So I mentioned it earlier when we talk about clinical use, those compelling indications there. Make sure you understand that in a lot of cases, we've said for medications with those compelling indications, caution, don't use it, can make worse. For ACEs, for post-MI patients, diabetes with proteinuria, heart failure, history of a stroke, coronary artery disease, or chronic kidney disease, use it. Drug of choice. So kind of opposite of a lot of the drug classes we talk about where those things will be a contraindication. Now we're saying, hey, chronic kidney disease, heart failure, strokes, coronary artery disease, any of those big bad ones, and hypertension, that's why ACE is in our backbone. That's why it's in our first line. There used to be in all the literature that African Americans did not respond as well to the ACEs, maybe due to a less active ROS system. The new guidelines still say maybe so, but it's still first line. It's still first line. So we used to teach. It used to be taught when I was coming up to use a different first line medication for African Americans because they might not have the same efficacy. But now it is first line drug. So you'll still see it out there and hear about it. And some people will say, oh no, you need to use a calcium channel blocker with a diuretic and stay away from ACEs. They don't work as well. Know the chart. First lines are first lines without any of the other contraindications we're going to talk about. But be aware of it because you will still see that in some literature, right? And it's on the slide. Still uses first line medication. Mostly renally excreted, the ACE inhibitors. Let me make sure I don't have anything else for you before we call it off for today. So we said it was good. The ACEs were good for chronic renal disease. They are, but guess what we have to do? Just like with all medications pretty much, labs and monitor, right? And look out for those adverse effects. But when we talk about the kidney specific, that the ACE inhibitors are renally protective, they are, but you still need to be looking at your BUN, your creatinine. We talked about, the lab work. Just when you're, the same thing when you're getting your diuretic. If you're on a diuretic, you're going to get the labs. You're also going to have kind of that same response with the ACEs. So you're going to get those labs as well. Now, often we don't just have folks in stage 1 hypertension, right? So that one drug from one of these almost always becomes add a second drug. So then we're going to be doing these labs there's some specifics as we get into some of the other players in the classes, but for the most part, we're going to check renal function on any patient on any antihypertensive as a rule. That being said, that is where I'll cut it off today. We'll get through Monday, I think it is, or Tuesday, the rest of hypertension, and then we'll just keep driving forward. Everything is cardiac until the last Monday of the semester when you take your test. So